It is a huge honor for me to be podcast interviewing Dr. Luis Carriere all the way from Barcelona, Spain. I'm here in Phoenix. It's 11:30 in the morning on a Friday, and it's 8:30 p.m. in Barcelona, Spain. Thank you for joining me today. I'm sure you're exhausted after a long day, and probably can't wait till this is over, huh?
Well, I am really happy to stay here speaking with you at that time. There's nothing else to do at that time that speaking with you.
Oh, you're too kind. And it's amazing. You have a dental degree. You have a doctorate in dental surgery, but you also have a master's degree, but you also have a Ph.D. doctorate.
That's it.
So you're a double doctor.
Well, a little bit, yeah.
And what made you go back and get your Ph.D.?
In Barcelona. In Barcelona, I was at the University of Barcelona, and I was studying about distalization and about the effect of the motion appliance and this and that and this.
Wow, that is just amazing. And you have your D.D.S. from Madrid, your master's from University of Barcelona. You received the Johnson E. Johnson Award from the American Association of Orthodontists in San Francisco, May of '95. The International Design Award from Delta Gold with the Carriere Distalization, member of the Editorial Review Board of the American Journal of Orthodontics and Dentofacial Orthopedics, contributing editor of the Journal of Clinical Orthodontics, inventor of the Carriere Distalizer and the Carriere Self-ligating bracket, invited professor at several orthodontic departments at universities in the United States, South America, Europe, and Asia. You're a speaker around the world. I can't believe that I got the honor for you to come tell us about what you're doing on our podcast.
Well, first of all, thank you, Howard, to invite me to be here. I am a strong follower of your interviews, so I am a fan of you, we could say. And I'm very pleased to be here today. And it's for me an honor to stay here for you.
Well, thank you. Do you want to just want to present your lecture? Would that be the best format for you? I mean, I don't think I'm smart enough.
No, it's an interview. It's an interview. No, it's an interview. Just what you were thinking. No? Oh. Just carry on with that, and we will play.
Well, yeah. Since you're the inventor of the Carriere Distalizer and the Carriere Self-ligating bracket, talk about your journey. How were you going along and decided to invent the Carriere Distalizer?
I am an orthodontist. My father is an orthodontist, and we have a family that we have been linked to orthodontics with the experience of my father and this and that. So he was my point of reference when I was a kid, and I wanted to become an orthodontist since I was very young. Then I started my ortho program, and at the same time, I had the chance, when I finished my ortho program, to go to start to work with my father. My father gave me also his input on top of the knowledge that I had on my ortho program. So it was very helpful for me. From another side, I have been always very much interested in technique, in technical aspects, in high tech, we could say, in three-dimensional and virtual reality aspects. So at that time, in 1996, I came out with a new program that was a virtual reality program, in which I was representing the orthodontic treatments. It was called the Softlander program, and was representing the 3D virtual reality, the orthodontic treatments in a totally interactive platform that was really out of the moment in terms of quality of graphics. It was designed to be not only a tool to learn, but also to distribute it to the orthodontist and make it something that was helpful for them. But it was so much advanced at that time that also we had a very interesting outcome that it was not that much successful in terms of being something of a lot of success in terms of a company, no? But from the other side, it was very successful from the aspect of the orthodontist, in which they were looking something from a new perspective, and this was the reason of the Joseph E. Johnson Award, basically.
And how does the Carriere Distalizer, what is it? What does it do?
Yeah. So then, after accomplishing that, well, I always have had the necessity of jumping and trying new things, this and that, and trying to simplify things, you know. And when I was realizing that things were a little bit difficult to me in certain aspects, I always had the intrigue to try to make it easier. So the motion appliance, because we call it motion appliance today, but the distalizer is the same appliance, was an invention or a design that I did in 2002 or something like that. You know? And at that time, I tried to make a kind of appliance that was able to correct the class 2 malocclusion, the class 2 malocclusion into a class 1 at the beginning of the treatment. This appliance was designed to move groups of teeth. Instead of moving a single teeth, a molar, we wanted to move the full posterior segment of canines, premolars, and molars into a perfect matching platform of class 1 at the first time of the treatment, at the first stage of the treatment. It means in the first 3 months of treatment of average, okay? So the objective was to convert a class 2 into a simple class 1 at the beginning of the treatment. And from that point, continue the orthodontic treatment in a simple way and in a much comfortable way, okay? So what I did was to try to design an appliance that was able to not only move that, but also was able to correct at different levels, all the posterior segment while doing the different things. First of all, move the posterior segment in a block into a class 1 platform. Second, change the occlusal plane and bring the mandible forward in a better sagittal position in relation with the maxilla. This change was not done by pushing roughly the mandible forward. No. It was a change that was, by changing the occlusal plane, was inviting the mandible to establish a new relation with the maxilla. But a side effect of that was that in many of our class 2 cases, the malocclusion brings the mandible back into a sagittal retruded position. This normally pushes the condyle to the distal of the joint and sometimes pushes excessively the menisc towards mesial. So by changing the occlusal plane and inviting this mandible to go in a better sagittal position, we were inviting in a very gentle and smooth way the mandible to get a better relation with the maxilla. This was very respectful with the mandible, with the joint, but at the same time was doing another thing, that was opening the airway of the patient because of this change. And not only that, was bringing forward the pogonion in a better sagittal position. So we were balancing the face. So a small appliance, then as a side observation, we saw that this was really making a lot of different, or creating a lot of different benefits in different levels that we were not expecting, you know.
Was one of the areas it was benefiting in treating sleep apnea?
Exactly. This is something that we, the orthodontists, shall brainstorm a little bit about. Because now we have been focused in orthodontics mainly or many times on the occlusion. The perfect matching occlusion, the class 1 occlusion of the molars, the perfect matching occlusion of the premolars and canines, the midline correction, and this and that. But we were isolating many times and too much on dental. But in my opinion, orthodontics is a specialty that is not mainly dental. Orthodontics is a specialty that is facial, is skeletal, and is dental. And none of those 3 areas can be isolated because the patient is a global entity, and everything we do on the hard tissues will have an expression on the soft tissues. So the positioning of the hard tissues will sculpture the beauty of the face. Okay? So that being said, what we were looking is for an approach in which we could solve the class 2 without the necessity of extractions that could diminish the volume of the bone and could diminish the support, the hard tissue support of the soft tissues of the patient, having a negative impact on the face of the patient. So this was mainly one of the objectives of the motion appliance.
So when you go around the world, what percent of the orthodontists were treating all the class 2s with extractions, say 20 years ago? And what percent do you think are still doing it today? How far along are you on your mission of getting people to stop thinking about a class 2 as occlusion and dental and start thinking of facial and skeletal and treating it more holistically?
It's interesting because we started with a company from Texas, many years ago with Class 1 Orthodontics. That now we are with Henry Schein Orthodontics, which they acquired. They acquired Class 1 Orthodontics. Okay, but we started, and from the beginning we had those what we call, or what everybody calls, the early takers. No, the orthodontists early takers who they were willing to try this new technology. And one of the things that happened from the beginning was that everybody that was adopting this technology was completely enthusiastic about it. So was a kind of doctor that was keeping going on the use of this appliance and making it as a standard in their office. Okay? So today, the conversion to our technology is massive, I could say. It's massive in terms of that there is a huge percentage of orthodontists that are using it. And everybody that is coming to our courses, I could say that is adopting in somehow the appliance in their offices. And we have a huge percentage of conversion because the appliance itself is solving and simplifying so much the orthodontic treatment that it's worth to using. This one is an appliance that was invented for class 2s. But then we realized that could be very useful for class 3s. And we started using it in class 3s. And now we have a tremendous use and impact on the class 3 malocclusion. And it's interesting because now, for instance, this month of April 2016, the Journal of Clinical Orthodontics now has just arrived. They arrived today to the office, arrived today to the office, and it's the first day that I have them. No? But it's the April issue of the JSO. Here we have an article. Of the treatment of class 3 malocclusion, of non-surgical correction of severe skeletal class 3 malocclusion. It's a beautiful article in which we can see an alternative, a serious alternative for the treatment of class 3 on those patients that reject surgery, and before we could not treat them so much as we would like in order to benefit them in terms of facial aesthetics.
Is it true that Japan has the highest percentage of class 3 malocclusions on Earth?
Well, I don't know really which is the population that has the most amount of, the biggest amount of class 3 malocclusion. Japan is one of them, of course. Japan always has been very much intrigued and very much early adopting the class 3 motion appliance. We have Dr. Kaku, which is a fantastic class 3 user of the motion appliance in Japan, but the population of Japan, certainly they have class 3s. But there is also another use of the class 3 motion appliance. When we get older, at the same time that we are getting gray hair or we are getting wrinkles, at the same time, we are having certain crowding of the lower incisors. And this small crowding is a kind of evolution that we shall always expect as long as we get older. So this lower crowding, if we want to solve it back and put it back in a correct and straight position, what happens is that when we place brackets, we will procline in a little bit the incisors, and this could diminish the beauty of the supramentally sulcus. And this is something that is not attractive, because then we are not going to have a beautiful facial outcome. So what we do with those cases of class 1 with lower crowding, and in which we want to solve the crowding, but we do not want to procline because it has an effect of diminishing the supramentally sulcus. What we do is that we start with the class 3 motion with an Essex or a passive vacuum aligner in the upper. We start with class 3 elastics, and we open slim spaces in between the lower incisors. This is going to create the perfect scenario for the perfect alignment of the lower incisors without proclining. The same happens with the slim crowding in the upper. We don't want to procline, so we always open with the class 2 motion appliance, slim spaces, even though if the case is in class 1. So the future will be, instead of talking about the class 3 motion appliance or the class 2 motion appliance, in the future I would like to start talking about the maxillary motion appliance and the mandibular motion appliance, because we use it in many different scenarios.
It seems like about just recently, obstructive sleep apnea has been all over the press, and now the New York Times #1 best-selling book is The Sleep Revolution by Arianna Huffington, who's the owner of the Huffington Post, who is one of the largest online news organizations. What do you think about all the focus on sleep apnea, and how does everything you're doing tie into that?
Yeah, very good. Thank you, Howard. Well, you're in Phoenix, right?
Right.
Yes, we have an annual symposium in Phoenix in which we meet in February. And in that symposium, one of the points that we talk about very strongly is the airway-friendly orthodontics. With orthodontics, we can really boost and help a lot on the airway permeability and on the airway canal. So, because normally the class 2 malocclusion is a kind of malocclusion that is really obstructing the airway. So by changing the relation between the mandible and the maxilla, we are opening the canal and we are creating a scenario of prevention of sleep apnea and all the problems that arise from obstructive airways. Now, we in this symposium, we have great speakers like Lou Shimura, like Dave Paquette, and like Sim Carlson, and Luke Quintero, and GC Quintero, that they are very much on top of the airway as well as we are, So we brainstorm about how is airway-friendly orthodontics and how we can prevent and how we can create the scenario at the beginning of the life for our patients in order to do not be falling on top of these technologies that now are really so much trendy because the airways of many people are very obstructed, So I think it's a must. It's a must that we, the orthodontists, that we, the dentists, we really pay a lot of attention to the airway of our patients. We have tools. Now, I just acquired the iCat Flex. The iCat Flex is an amazing machine. It's an amazing machine in which we will open a new revolution for the control of the airway and from the prevention of that, and how we will be able to study how we can prevent and boost our treatments in a better scenario.
It is amazing how in the 30 years I've been doing dentistry, it's moved from mostly a dental occlusion specialty to now an oral systemic link, the whole body, the whole, you're going from a dentist of the mouth to thinking about how it relates to the entire body.
Mm-hmm.
Have you noticed
Sorry.
that? Have you noticed that trend? How well you talk about how dentistry and orthodontics has gone from being more occlusion dental related to facial, skeletal, the oral systemic length, sleep apnea.
Absolutely. I think that the mouth and the oral health is one of the elements that can be the starting point of many systemic problems. Okay, so dentistry and orthodontics, in my case, because I am an orthodontist, dentistry should be related to keep the health, especially of the gums, and the teeth, of course, but to create the scenario of function, of alignment, of prevention, of any gum disease, any periodontal disease, or any problems of crowding that could bring problems that could be hidden by the crowding, but are there, that could be making the start point of systemic diseases that can really bother the patient. So in terms of prevention, dentistry has a lot to say on medicine, a lot, and has a big impact on the general systemic health. At the same time, with orthodontics, we can balance the face of the patient. We can make patients happier. Not only that, we can balance the spirit of the patient. Why? Because if you give the good harmony to a face of somebody, we are working on the most contemplated foot square of the earth, which is the face. You are looking at my face, I am looking at your face. I cannot hide this. You cannot see if I like bacon because I can cover that with my shirt, right? But you can see my face, and I cannot hide that from you. So we have to give harmony to that, because this is the tool of the self-confidence and happiness of the patient. It's the tool to find the love of their life. It's a tool to find a job. It's a tool to find a social capacity of being happy in their environment. So we are working in a very sensitive area.
When you lecture around the world, is there a big variance of how orthodontics is treated, or are there different camps in different countries, or is it really more homogenous?
Orthodontics is a specialty that I like to say that has a little bit of geological changes. Why geological? Well, because few new things and a lot of evolution on things that they already exist, but few new things. So this, at the same time, the orthodontist is a specialist that is very intrigued by what's going on. So I could say that I am traveling all over the world in a constant basis, and I could say that the level of orthodontics everywhere is more or less the same. We have very few differences, and we could say that is a globalization of knowledge and quality of care globally. And this is very interesting and rewarding as well to see how the evolution is going.
One thing I've noticed that no matter what country I go to, Invisalign has exploded from South Africa, Malaysia, Tokyo, everywhere you go. Invisalign. What are your thoughts on the explosion of Invisalign?
Invisalign is a great technology. Invisalign is, and when I say Invisalign, I say any aligner technique that aligns without the necessity of brackets. Okay, but for instance, we are talking about Invisalign because it was the first one, and now it's the biggest one on the field. So it's the boss on this area of aligners. Today, But so Invisalign is a great technique. But at the same time, or technology, more than the technique, is a technology. But at the same time, this technology has to be used properly, because we know that we can align with the clean check everything, but we have to give as well the perfect occlusion, the perfect scenario of occlusion. So with Invisalign, sometimes we try to solve malocclusions that have sagittal discrepancies, even if they are class 2 or class 3, and this means that we need to do many aligners. For instance, a full step class 2 treated with Invisalign, we probably would need 95 or 100 aligners. So this is a kind of approach that this would not be affordable in terms of time from the patient. The option is to extract a premolar, but the extraction of premolars would be a negative effect on the face of the patient, so also is not acceptable for the patient. So today, one of the most trendy concepts that we can find out there in the world, not on dentistry, in the world of innovation, is the word hybridization. And what does means hybridization? Hybridization is to take something from the field that does not belong to our technology and bring it in our technology in order to boost and put our technology in another level. So how we can hybridize the motion appliance, for instance, with Invisalign? Well, imagine a case in which we have a class 2. We have a class 2 with the motion appliance, we place the motion appliance, and we convert the case into a class 1. By converting the case into a class 1 and removing the motion appliance in the first 3 months of treatment, in an average, then what happens is that when we do the clean check, probably we can end up with 14 aligners, 20 aligners, short period of time of aligners. We really shorten the period of time of aligners, you know? So at this point, hybridization is very important. We took that point very seriously. So we have created what we call look at that, Howard, we have created the aesthetic motion appliance, the clear motion appliance for Invisaligners. So now we are presenting, and we presented in the American Association of Orthodontics last month, we presented the class 3 Carriere motion appliance. And it's going to be in the market this July. So we are very proud and happy that we have created this tool of hybridization to put in a new level the Invisalign treatment. You know?
I wish you would make an online CE course up for Dentaltown too. The Dentaltown has 215,000 dentists, 5,000 of them are orthodontists.
Yeah, we can do it whenever you like.
I would absolutely love that. That would be amazing. Also, since Dentaltown now is on the app of the 50,000 of those 217,000 dentists have downloaded the app, so
I'll do it. I'll do it today.
Oh, that would be amazing. So, where is how long on your journey did that go from the newly designed Carriere self-litigating bracket system?
Well, you know, we have the motion appliance for starting the case. Okay, we have a class 2. We put the case in class 1 at the beginning of the treatment. If we have a class 3, we put the case at the beginning of the treatment in class 1, and from that point we treat it or with Invisalign or with brackets. One of my obsessions is simplification. And the second part of the treatment, I wanted to have a simplified approach for our treatments. So I designed the Carriere SLX bracket, which is a passive self-ligating bracket that I could say that is a high-performance passive self-ligating bracket. We had the opportunity to work with the best engineers. We started before with the former Carriere SLV, which was my first design. Then we made the evolution, and today we have the Carriere SLX or the new SLX, the new Carriere SLX. This bracket is outstanding. Why is outstanding? Well, because as we did with Emotion Appliance, we had the opportunity and we were blessed to be able to work with the best engineers, with the best people, with the best team, to everybody, put them on top of the project and make them work as a team. We work all together and we accomplished the highest level we could say we could work, making all the work perfect. So we now, I'm very proud to tell you that this bracket today probably is the best bracket out there. Probably. Because the level of accuracy that this bracket has, the level of precision that these torques have, and every that is connected to this mechanism of self-ligating bracket are out of this world. Well, it took almost 5 years to arrive into this SLX design. It took almost 5 years because we were pushing at the highest level and stressing at the highest level our engineers and saying no, better, and we finally got that and delivered the product in the market when it was perfect, you know.
And where are they sold at? What is the website where do you sell these at?
Everything that is connected to Carriere is Henry Schein Orthodontics, which is the orthodontic brand of Henry Schein, and it's and everything is out there with them. You know, we have the exclusivity, and it's globally. So it's global, and you can find it in US, you can find it in Japan, in everywhere you could think in the world is there. You know.
Stan Bergman really made that a global country. I think he has offices in 56 countries or something. Just amazing.
Absolutely. Stanley Bergman is a man that I had the opportunity of meeting several times, and he impressed me a lot first of all, for how humble he is, you know? And he's a kind of man that you cannot imagine how big is the company he's running, and so humble he is. No? But at the same time, what I really like it is the values. Is the values that he and the company has, no? Because the company has a real interesting and nice values, and is one of the strong points why, in my case, I decided to stay completely and exclusively connected with Henry Schein Orthodontics. You know, its values of bringing the best to the society, values of trying to give the best for the profession. It's not everything about money, absolutely not. It's about relations, it's about health, and it's about good word and good work, you know? So I could say that I feel very blessed to be with this company today, and well, it's something that I could never imagine in my life to have this honor. And
can I tell you a funny story about Stan Bergman and his values? Twice, I've been on a missionary dental trip out in the middle of nowhere, and all of a sudden I find this beautiful dental office completely built and paid for by Stan Bergman and his family and foundation. And so I'm in there working on all these orphans, and I tell them that my friend Stan is the one who built this. So I pulled out my iPhone. I said, I want you guys to all tell my friend Stan, thank you for building this free dental clinic. And with the language barrier, when I said, okay, tell him thank you, they all started singing happy birthday.
Absolutely. You know, it's a company that is wealthy, is very wealthy, because they work very well. But this wealthiness, it returns to the society with these aspects, with these things. And this is why we are so proud to work with this type of companies. Because I'm not interested in just business. No. It's interesting to give a payback to the society when something is going in the correct direction. You know?
Yes, I love Stan. when you look at the specialties, like orthodontists, in particular, endodontists, it seems like some countries, like the United States, where almost a quarter of the dentists are specialists. And then it seems like other countries really haven't adopted specialists much. Is orthodontist a more popular specialty in some countries and not very popular in other countries? Have you noticed that?
Orthodontics is a specialty everywhere. It's a specialty everywhere, but at the same time, normally it's very much demanded. There is a big demand on all the ortho programs. You have a big demand of doctors that want to become orthodontists, and they apply for becoming inside of the program, for getting accepted in the program. So it's a massive interest on the orthodontics, And I could say that everywhere is the same. Everywhere. There is no difference on that. So,
and the United States has 10,000 orthodontists, and then the next largest specialty is half that size, like 5,000 oral surgeons. And I think one of the reasons is no matter what country you go to Africa, Asia, Malaysia, Indonesia, and you see all these girls have found the money for an iPhone and Invisalign. So I mean, they first want to buy their iPhone, their smile, their makeup, their lipstick, their high heels, and they'll buy that before they buy almost anything else.
Yeah, absolutely. And in terms of prevention, I think I am not a specialist, but I know a lot of people from the implant dentist, implant area, implant world. Okay, but I think the U.S. is one of the countries that is less demanding dental implants. Less demand. Is one of the markets that is less strong in terms of the need of dental implants. Okay, and why is that? Because in US, orthodontics has been popular since many years ago. So the prevention, the new scenario of good alignment, the good function, and the absolute interest into having a good set of teeth with a good alignment is preventing the loss of teeth in an adequate moment of life. So this is the reason why prevention is so important. Orthodontics has a lot to say in terms of prevention. A lot to say.
That is a very interesting observation. What also, one subject that comes to mind with everyone's who's had orthodontics or their children is how long do you wear the retainer? How long do you try to hold retention? You get so much relapse in the lower anteriors over time, especially you're doing ortho on a young child who may live to be 80 years old.
I always say the same. When we treat a class 2 or a class 3, we can expect two things. One thing is that what we have to do is to create the scenario of stability in order to have the sagittal problem solved in a long-term basis for the life of the patient. So we cannot expect finding the patient in 3 years, if it was a class 2, with a class 2 after 3 years of treatment in the supermarket, right? We are not interested in that. So we have to generate the scenario of accomplishing a perfect occlusion that really creates stability for this occlusion. So we cannot accept relapse on that point, at that level. But we have to explain to the patient that there is a kind of relapse that will be always there, and we have to fight, and we have tools to fight it that are artificial. This relapse is the lower crowding of the incisors. This is something that sooner or later will want to arise because the occlusion is forcing into accomplishing this and into bringing those lower incisors a little bit crowded. Okay? So what we do, we place wires behind of the incisors, or we place an S6 to keep this S6 on. But I never, in my profession, I never said to the patient, I never said to a single patient, don't use anymore any kind of retention. Never. To a single patient. I never said, patient, never again use your retainer. I let them get exhausted of it, and that's all. I say, hey, use it if you can forever, use it, because the life will want to have lower crown. I am not a super fan of the bonding of the lower retainer and behind the incisors, because I like the flossing, and I'm very much interested in flossing, But in certain cases, and in many cases today, we are placing it. But I always train to say, hey, please use the super floss, which is because it's very important, the gingival health, And we always take care that there is no inflammation of the gingivitis or this and that. But I mean, retention should be forever.
Dr. Carriere, some, humans are extreme. Some say that there should never be an extraction of a tooth for orthodontics. Some say, some say never. Some say 20% of their cases. Some say 30% of their cases. What percent of cases around the world do you think should be extraction? Do you think none of them should? 10%, 20%? What do you think?
I think we have to distinguish in the type of extractions. There are two types of extractions. Two. One of them are the extractions that are performed in order to sculpture the face in a more natural and beautiful and elegant and attractive scenario. For instance, a biprotrusion when the patient has the two upper and lower lips forward, in which if we extract 2 or 4 bicuspids, we reposition the incisors in a better retrusive position, and then the patient gets a balance of the face. Those extractions are welcome. Those extractions, we are happy with them. Those extractions are in the area of the office in which we are happy to do them. Now, there are another type of extractions that, in my opinion, should completely disappear from the profession. And those extractions are the ones that are done because it's the way that the doctor is treating, is the technology that the doctor is using, is the technique that the doctor is using is going to need for extractions or 2 bicuspid extractions. Those are not acceptable because are not based on the face of the patient, and those are giving a negative impact on the face of the patient. So any face that we cannot give the beautiful outcome is a patient that will not be happy, is a patient that will not be self-confident, is a patient that will be sad. And many times, this sadness, if the patient has 15 years old, will be elongated for maybe 85 years. And Howard, how long is a period of sadness of 85 years? Because the orthodontist maybe was not in the classroom that day. So, I mean that we are in a profession in which we are permanently studying and seeing which are the new techniques and which can be used in order to decrease the necessity of those extractions that are linked to mechanics and not to face. So I think our objective with the motion of lines is completely remove those unnecessary extractions and welcome the necessary ones. Now, the necessary ones, today with these technologies, are very few. So the decrease of the extractions are dramatic. As well, I can say that many treatments of crowdings that have been treated today with the capacities of the self-ligating brackets like ours. We have a passive self-ligating bracket. Sometimes we want to treat crowdings and we bring forward incisors unnecessarily. So we can also ruin faces if we do not accomplish the adequate, steady protocol to create the scenario to balance the face. So it's a matter of faces. In my opinion, orthodontics should be the first specialty on facial aesthetics for a consultancy of any patient that would like to have a more beautiful aspect. Why? Because the orthodontist is able to move the hard tissues of the patient and sculpture the face of the patient in a very natural way. Then, if the patient is not happy enough with what we can accomplish with orthodontics, then it's the time of going to another professional of facial aesthetics. That could be a maxillofacial surgeon, could be an aesthetic surgeon, could be whatever, you know. But number one, in my opinion, orthodontics.
I want to ask you the same question, but regarding bruxism. Some orthodontists, some specialists think that everybody that bruxes, it's in response to sleep apnea. Some people say it's half, some people say it's a quarter. How prevalent do you think bruxism is to sleep apnea?
I have no idea of which is the link percentage or in between bruxism and sleep apnea. I think the real experts on the treatment of the active and not prevention of sleep apnea, the treatment of the already established sleep apnea are those ones that they really manage those numbers. And we have, for instance, Lou Shimura that is having a practice that has a lot of these patients. Probably he could tell us this, which is the link on that. No, Lou is coming. By the way, we have in September in Barcelona, Howard. Look at your calendar. We have at the W Hotel in Barcelona a beautiful meeting that is the European Carriere Symposium, in which we are treating the sleep apnea problems with Lou Shimura. We are treating the also the obstructive apnea diagnosis with Sim Carlson, talking about the 3D stuff with the iCat Flex, and we will have Dave Paquette as well. We are having John Kaku from Japan. We'll talk about the benefit of the airway condition with the motion appliance, etc. I will be speaking as well, so it will be a very nice meeting, you know, in September, at the end of September.
And what is the website link to that meeting? Do you know the www?
Carriere, Carriere, carrieresymposium.com. It's very easy.
Did you find it, Ryan? Well, you don't have to twist my arm to get me to go back to Barcelona.
You know, we will feed you, we will keep you like a king, and you will go home with tears in your eyes.
Okay, if I'm not lecturing that date, I'll be there. I want to ask you another question. You know, around the world, the United States is a big country. There's different occlusion camps. Some, you know, call it, I would say CR or neuromuscular. The CR is like the Pankey, the Dawson, the Coyce, the Spear. And then there's another camp that's more what they call themselves neuromuscular. Do you see those two camps? And can you are they very different to you or
what do you mean on the first camp?
They call themselves more CR, central relation occlusion, and then the other camp's more myofunctional, neuromuscular.
You know, in my opinion, everything is connected. It's not a matter of CR, it's not a matter of myofunctional, it's not a matter of function and just CR. I think there is no black or white in biology. There is gray, and always is a multifactorial aspect. You know, there is always a mix-up of both worlds. There is an important aspect of the function. It's very important. We give a lot of importance to the function in our office. The tongues, the position, the swallowing, the positioning of the tongue is really distorting a lot in orthodontics. It's really generating inflammation on the joints because the patient is not using the mandible as it should be used. The patient is moving the mandible as it should not be used. And this strange movement of the swallowing with the tongue is creating many problems at the DMG. Also, the scenario of the perfect positioning of the joint is necessary. We have to generate the good relation between the mandible and the maxilla in order to bring the disc at the adequate level, in order to eliminate the distal positioning of the condyles excessively to the distal in our class 2 cases, or the excessively medial positioning of the condyles in our class 3 cases. And we have to balance the relation. The TMJ joint is one of the most complex, is the most complex joint of the human body, the most complex. Because it's bilateral and it's free and it's a mess. So we have to balance everything in order to generate the scenario of centric relation and centric occlusion and adequate function.
And knowing that it's all tied together, it's not just mechanical occlusion, it's facial, it's skeletal. What are your thoughts on tonsils, adenoids, tongue-tied? I notice some people do a lot more lingual frenectomies, frenectomy. Yeah. What do you think of those three things?
Well, there are many of our patients that they have the tonsil surgery and this and that at the beginning, and they come to our office at a very early age in which they already had the tonsil surgery, okay? But there are others that they have that the difficulty of breathing with tonsils that are not massive, but are quite important. But with the expansion of the maxilla at the 7 years old, with the expansion of the maxilla, we generate the scenario of an adequate nasal breathing and functional breathing. So they are not falling on the necessity of the surgery of tonsils. I think, in my opinion, if it was my child, I would give always a chance for the orthodontist to solve the transversal. Once we solve the transversal, then if the breathing is not already adequate, then I would go for the tonsil surgery. In terms of frenectomies, we are if it is not a lingual, completely blocked tongue in which the patient cannot touch the palate, in terms of frenectomies, we are very minimally invasive. I mean that we have laser. I have an Epic BioLace, which I love it because I always, but I love it for gingivectomy. I look like a little bit like Star Trek with the laser. I love to make my gingivectomies and good the nice margin because the cases look twice better than when you finish with a natural, just touching the perfect level of gums. No? But at the same time, this laser is very useful for the frenectomies. It's very minimally invasive. Anyway, we do very few frenectomies in the office. Very few.
So what other things? I want to ask a more a political question, you might say. When should the orthodontist be doing this? And do you ever think it's okay for general dentists to do some of these ortho?
General dentists are trained doctors in which one of the areas that they cover in the university is orthodontics. So they shall know a lot of concepts about orthodontics and this and that. And we are a dentist, and we are professionals of the medicine, because the dentistry is an area of the human body and as a very important area in terms of prevention. Okay, so there is the number one aspect in medicine that is try to do not harm. Okay, so this means that we as doctors, general dentists, or as doctors, they have to know which is their knowledge in terms of orthodontics. Once they say, hey, this is where I can arrive and I can benefit my patient, perfect. If not, it's better to send it to the orthodontist, because the most important thing, the start of our offices is the patient, is the human being. We are in this profession, in my opinion, we are in this profession for helping the others with our knowledge in our areas, you know. So I think it has to be falling on top of the responsibility of the GP to say, hey, now this is something that I prefer somebody that is very expert on that to do it, because maybe I will not be able to accomplish what I need to accomplish with you, no?
Do you think clear aligners like Invisalign or Clear Connect or what have you reduce the amount of demineralization? Some of the people who get orthodontics, they don't have as good of brushing or flossing or fluoride. Do you think removable clear aligners reduces demineralization?
Absolutely not. Absolutely not. Yeah, today, depends, because I am talking from my side as a 100% user of passive self-ligating brackets or aligners. So I am talking from my perspective. Now, there are many orthodontists that they work with traditional ligation. What is the benefit of the passive self-ligation? Speed of treatment, first of all. We can end up the treatments so fast. And the second time is we do not use the O-rings, the silicone O-rings. So the bugs coming into the periphery of the teeth are much less. The time of the brackets in mouth are much less. And we don't find problems today of decalcification. So if you ask me if there is more or less, I could say it's exactly the same. Now, when I was working in the past with my ligatures, then I saw some decalcifications, you know, and this was because the elongation of time, because the capacity of the silicone to attract water and to attract bugs and to generate some metabolism of acids in the area in which we are connected to the teeth. So in terms of traditional ligation versus aligner, probably I could say yes.
One more question. It's 58 minutes, and I know it's late there. I know it's 9:30 at night. But my last question is, do you think you can still do great orthodontics with two-dimensional pano and ceph versus the new three-dimensional CBCT cone beam? Do you think cone beam is necessary to do great orthodontics, or do you think it can still be done with two-dimensional pano?
You know, I think we can not do it exactly the same. So this is the reason why I just acquired my iCAD Flex, because I am a strong believer that the three-dimensional understanding of what we are doing, it's going to upgrade our profession. Absolutely, no doubt about that. But I was waiting for the adequate technology, because one of the other things that really concerns to me is radiation. So today with the iCAD Flex, we have a very low dose of radiation as a panoramic X-ray with the iCAD Flex, and we have a three-dimensional understanding of the patient. So this is the reason why, in my case, I waited so long to have a 3D iCAD, you know.
So you like the iCAD Flex?
I love it for two reasons. One of them, and the most important one, radiation, levels of radiation. A 3D image of the patient is less or equal, I think it's less. Sean Carlson, which is the expert on that, it's explaining that in our symposium, and in Arizona as well, in the technology meeting we are having in February, is going to explain again on that. But is the same or less, I don't remember, than a panoramic X-ray. No? a digital panoramic x-ray.
Well, that was a very fun hour, Dr. Louis Carriere. Thank you so much for spending time. And you think you might create an online CE course for us on Dental Town?
It will be a pleasure, Howard. Everything with you, it's a must.
And I hope that my son Ryan and I get to have dinner with you in Barcelona.
Be sure about that, huh?
And if
you said it, and it's recorded, okay?
And if you come to Scottsdale, same thing. You got to call me up when you get to Scottsdale.
I will be in Scottsdale in February. It will be it's the Arizona Symposium. You are invited to this symposium, so you can come. You join us, and we have fun. You will meet a lot of friends. Last year we had Jim McNamara, Professor McNamara, giving a beautiful lecture, and many doctors. It's a great set of speakers in Ortho.
Well, I can't wait to see you in both places. Thank you so much for an hour of your time.
Thank you to you, my friend.
All right. Have a great evening. Good night.
Same to you. Bye.